Good afternoon. This is Anita Castleberry. I'm the medical assistance manager for the Medicaid Behavioral Health Unit, and I want to give you just a short overview of how we've come to this point in preparing for the ODD, oppositional defiant disorder episode. We have a core work group here at DHS that coordinates the behavioral health episodes. Through that core work group, we have done extensive outreach through a clinical stakeholder work group, and we've held a public hearing to disseminate information as this episode was being developed. It is out for the policy related to this episode is out for ended in public comment on April the 13th, and we'll be going to legislative committee in May or June for promulgation. With that said, here to give you a preview of this new episode and how it was developed and what it will do is Dr. Justin Hunt. Dr. Hunt started as a vice president and the medical director of the Value Options Arkansas Service Center in July of 2012. Prior to joining Value Options, he was on faculty at the UAMS Psychiatric Research Institute for 3 years as an assistant professor of psychiatry. And we are very glad to have Dr. Hunt. He has hit the ground running and has been very instrumental in leading the discussions through the clinical work group and assisting with the development of this episode. So with that, I will turn the presentation over to Dr. Hunt to give you the real information that you're looking for.
Thank you, Anita. So we're going to spend some time today just kind of looking at the clinical foundations for the oppositional defiant disorder episode, as well as some Arkansas-specific claims data that shows kind of currently what's going on in the state of Arkansas with respect to treatment for oppositional defiant disorder. So first of all, we'll start out with this slide, which basically demonstrates a guideline concordant treatment pathway for clients diagnosed with ODD. So naturally, kind of the first step in the process of treatment, really of any behavioral health disorder, is a very thorough assessment and that is performed and then results in a diagnosis, of course, in this case, of oppositional defiant disorder. A licensed clinician then confirms the diagnosis and is then responsible for the care. And there's also parent and caregiver notification. And often in the case with oppositional defiant disorder, the families are highly involved from the beginning in the initial evaluation, and because their information is critical actually in making the oppositional defiant disorder diagnosis. So again, I can't emphasize enough the importance of a thorough assessment before really starting any of the behavioral health episodes. And then the next block is the treatment block, and this information is based upon a thorough review of the literature, as well as expert interviews that the McKinsey team performed, as well as input that we received in our multiple provider work groups on ODD. So basically the initial treatment plan for the first oppositional defiant disorder episode of 12 weeks or 90 days is basically 2 visits per week. And this was, again, based on the literature and evidence-based programs that are out there that address ODD. And those 2 visits can really represent individual therapy or family therapy. Certainly, just given the nature of oppositional defiant disorder, we would like to see a fair amount of family therapy in the treatment regimen. Based on the literature, approximately 40% of the population improve after 1 episode or 90 days of treatment at this intensity of approximately 2 visits per week. If If the beneficiaries don't improve, then it, of course, is important to kind of reassess the situation, reevaluate the patient to see if ODD truly is the target diagnosis, and also to determine what kind of changes in the treatment regimen need to happen to promote recovery. And then, of course, you could have a second treatment plan or a second ODD episode, again, of 12 weeks or 90 days, and the target treatment per week would be approximately 2 visits per week, and with a mixture of individual and family therapy. The evidence shows that after that second episode, an additional 30% of that population then improves. So you can see that a fair amount of beneficiaries with oppositional defiant disorder are going to recover from the disorder either after one episode or two. We do feel like it's important to mention medication and its relationship with oppositional defiant disorder as well. We really see it as a useful adjunct, not necessarily for the oppositional defiant disorder, where really the evidence-based literature shows that therapy, both individual and family, is the evidence-based treatment for ODD. But medication could be helpful in the case where you have a child that has oppositional defiant disorder and a comorbid diagnosis like ADHD. And in that situation, of course, if you have a comorbid diagnosis, they wouldn't be in the ODD-only episode, but medication would be appropriate for a diagnosis such as ADHD, but not really for ODD only. And we'll talk a little bit more about that in a future slide. And then, of course, anytime you provide treatment in this episode format, or really anytime you provide treatment, you need to monitor the overall outcomes too, so the effectiveness of treatment. The reasons why a second 90-day episode or 12-week episode is needed for a child with oppositional defiant disorder. What exactly is going on in their family situation where they might be more severe, where they would necessitate a second episode. And then of course, continuing care. So how do you, once they recover, how do you then provide infrequent booster sessions to keep them from developing oppositional defiant disorder again? So on to the next slide. Oh, sorry. Oh, look, I got it. Thank you. Okay, and so this slide kind of really gets more into the Arkansas specific data on non-comorbid, so again, this is ODD only, clients treated by individual providers in the state of Arkansas. This data represents episodes which are defined as a 90-day treatment program that ended in state fiscal year 2010 and 2011. So it represents 2 years of data in the Medicaid population. So basically this graph is demonstrating the distribution and the number of patients and how that relates to the number of providers that care for each one of these groups of numbers of patients. So, for example, the 54% of the providers have a client list of just one to five beneficiaries that have ODD, but that only represents 0.8% of the total episodes. Over here on the far right, 5% of the providers have 101 or more clients treated for ODD only. So it's only 5% of the providers, but 46% of the episodes live amongst those, that relatively small number of providers. Looks like it's about 20 or 25 that have that many clients. And then, and perhaps the most important line to keep an eye on is this bottom one that lists the average episodes per client. And you can see it varies depending on the group that we're looking at here. But it hovers around the two episode range. So that represents 2 90-day treatment programs for the beneficiaries. So again, just kind of give you an idea of how many beneficiaries there are out there with ODD only and how that's spread across providers in the state of Arkansas. Here, now this gives you an idea of the spend on ODD only. And fortunately, concordant with the evidence-based programs that I mentioned earlier, the most frequent services provided are actually non-medical interventions. And basically the way that we're describing non-medical interventions, it's all psychotherapy, counseling, community support, and therapeutic activities, as number 3 says on the bottom of the slide. And this is what we want to see. So the total spend is $19 million over here to the left, and $13 million of that is spent on these non-medical interventions, and that's 68% of the total cost. And fortunately, 92% of the episodes have the occurrence. We, of course, would want to see that at 100%, given that the evidence-based treatment for oppositional defiant disorder is therapy. So you definitely want to see non-medical interventions in there. And you can see how the assessment, testing, and office visits breaks out. $2 million is still spent on medications, and again, based on the literature, medications are not really indicated for oppositional defiant disorder only. We had some pretty robust discussions in our provider work group about this topic, and they are sometimes used to, kind of calm beneficiaries' aggressive behavior, so they then can engage in the therapy that's indicated for ODD. So we think that's some of where the spend is occurring, but still, it's a pretty high number. Almost 40% of the episodes in this 2010, or this is actually 2011 state fiscal year data show medications to treat ODD only, and that's just not in line with the evidence-based treatment. So that's one thing that the episode is going to target in the quality metrics. This next slide, it just demonstrates that the behavioral health providers provide the vast majority of ODD care in Arkansas. And behavioral health providers is also sometimes known as RSPMI. So you can see the total spend on ODD only is $19 million, 18.5 million of that is in the behavioral health provider organization. So it's really a pretty small number where people are going to kind of lone providers, either PCPs or kind of psychiatrists that are not associated with a behavioral health provider organization. And you can see how the episode count breaks down as well. 10,225 of the episodes live in the behavioral health provider organizations versus 190 in the PCP or psychiatrist category. And then there's also a very small number in the other category, which basically represents FQHC providers, non-behavioral health providers, school-based providers, and non-standard providers of care, as the bottom says. And the episode costs, you can see at the bottom, does kind of vary by the different provider as well. It's, as you can see, it's slightly higher for the behavioral health provider organizations at $1,782 per episode versus $1,311 with PCPs or psychiatrists kind of in solo practice. So a little variation there. And that's not overly surprising given kind of the robust services provided in the behavioral health provider organizations. And this is another kind of very interesting slide. And basically the takeaway point here is that almost a third of the clients are receiving care above and beyond what is actually recommended in guidelines from kind of leading professional organizations and also evidence-based treatment. So the way this was basically calculated, kind of the magic number of $2,160 per episode was calculated based on 1 to 2 treatments per week for 12 to 14 weeks. You can see number 1 at the bottom of the graph kind of delineates that calculation. So that's where the red line exists on the graph. So, still we have 68% of the clients are on the left side of that red line, which represents episodes that there's not excessive care. But then if you go on the right side of the red line, you have a third of the clients that are receiving too much care, and then interestingly enough, those clients, which are just a third of the clients, represent almost 2/3 of the total spend on ODD. So you can see kind of the importance of developing an episode of care when you have that kind of level of extra care beyond what's even recommended in the literature.